So the heart rate is primarily going to be controlled by the pacemaker, the SA node. And just remember that if I increase vagal tone to the SA node, that's going to be parasympathetic. So that's going to cause bradycardia. If I decrease the vagal tone, that would be allowing the sympathetic nervous system to have more of an influence, increasing the heart rate, potentially causing tachycardia. Okay, so just remember where this kind of all comes from. And we'll talk in much more detail about this in the electrical physiology videos. Now, I also want to remind you that coronary perfusion, so when we're talking about the perfusion of the heart, is primarily going to happen during diastole. And this is particularly true specifically for the left ventricle. You can imagine that in systole, the pressures are going to be very high in the left ventricle. We're having a contraction, generating very high pressures. It's not allowing those tributaries or those arteries that are supplying the heart to get blood perfused because the pressure is so high, particularly in the subendocardial region. Okay, so the subendocardial region is actually going to have the highest pressures of all in the left ventricle, okay, during systole. And so this area is the most susceptible to ischemia. Okay, and that's also particularly high yield to remember. Point is that we have coronary perfusion during diastole. When the pressure is lower, those coronary arteries that are surrounding the left ventricle, they're able to get perfused because there's a huge pressure drop. So all of that blood from the aorta is able to immediately go to those coronary vessels and supply the heart during diastole. Now, I'm going to talk about cardiac output in just a moment, but you can see that the heart rate actually plays a role here in the cardiac output. If I take the stroke volume, the amount of blood that's ejected with each beat, multiplied by the number of beats per minute, it gives me a cardiac output. The last thing on here is just a little bit about tachycardia. So the idea here is, based on our formula here, we can see that as the heart rate goes up, the cardiac output should also go up, right? Because I'm having more opportunities, more beats per minute, so that's more opportunities to eject this stroke volume out to the rest of the body. However, this is only true up to a point. So let's just say that here we have a heart rate of, I'm going to put 40, and then let's say we have a heart rate of 100, and then maybe we'll say 180, and then 240. Really high heart rate here. Okay, so initially what's going to happen is, my heart rate, as it goes up, my cardiac output is going to go up. But eventually what will happen is, and by the way, this is going to be my heart rate, and this is going to be my cardiac output. So as my heart rate goes up, you can see that initially up to a point, okay, I'm going to have a higher cardiac output, just like the equation says. But once I get beyond a certain point, a certain threshold, there's kind of an inflection here. As the heart rate goes up, the cardiac output comes down. So why does the cardiac output come down at high heart rates? The idea here is that we have less time spent in diastole, okay? And so I don't have enough time to actually fill the heart. If my heart's beating at 240 beats per minute, just think about how many beats. That's 4 beats a second. At that point, there's really not enough time to fill the heart with blood. And so what are we, ejecting when we contract? We're not ejecting very much blood. We need more preload to the left ventricle so that we can have more lengthening of our sarcomeres, higher contractility, right, and more blood ejected. If I can't bring blood back to the left ventricle, I'm not going to be ejecting very much blood at all, right? And that's what happens at higher heart rates. So that's why we have this inflection point. As we start to get in really high heart rates, I don't have enough time to fill the left ventricle to eject the blood. And so that's the concept. And so you can imagine, if you thought about this mathematically, the stroke volume is basically plummeting as we get to these higher heart rates. And this is also true for the heart itself, right? So remember, the whole point that I just made was that the coronary perfusion is happening during diastole. If I don't really have any diastole, I'm not going to be getting a lot of perfusion to the heart. So these patients at very high heart rates are at risk for significant ischemia. In which region? Initially, the subendocardial region, right? That's what we just said. And again, this eventually at higher heart rates can cause decreases in cardiac output. Also, just an equation to remember, just remember that the maximal heart rate that one should be able to achieve is going to be 220 beats per minute minus the age in years. So if I'm 20 years old, right, I would just take 220 minus 20, so the maximal heart rate should be about 200. Someone that's 40 years old, right, it would be about 180.